Me to share this dais for taking class for our beloved PGT students. And this is my third class. In first class, I described growth monitoring. In second class, I described how to approach a case of cyanotic heart disease. And this is the third class. And it will be on persistent and chronic diarrhea. It's a very interesting topic. I have made slides in such a way that it will be very much helpful for our PGT students. So today my topic will be on persistent diarrhea and then chronic diarrhea and malabrasion. So first I will discuss on persistent diarrhea. And it's a very simple thing, you know, most of the diarrhea subsides before 14 days. But if any diarrhea which presumed to be infectious in etiology starts acutely and lasts more than 14 days, that will be called as persistent diarrhea. At the same time, we have to remember that chronic or recurrent diarrheal episodes such as tropical screw, gluten-sensitive enteropathy, and hereditary other disorders will be excluded. So any diarrhea presumed to be infectious in origin starts acutely, lasts more than 14 days, will be taken as persistent diarrhea until proved otherwise. So few figures regarding burden of persistent diarrhea. 10% of diarrheal episodes becomes persistent. That means persists beyond 14 days. 35% of the death in children is less than 5 years of age. 7 cases per 100 children per year is the incidence, and 20% of acute diarrhea in malnourished persists beyond 2 weeks. And we know very well that diarrhea and malnutrition runs in a vicious cycle. A slide move করছে? Hello?
slide move করছে না, move করছে না, move করছে।
ওখানে তো আমি পারবো না আজকে।
ক্লিক করে করে করতে হবে। এইবার হয়েছে ফুল স্ক্রিন।
ফুল স্ক্রিন হয়েছে?
হ্যাঁ।
ঠিক আছে। So this is the burden, and 60% of persistent diarrhea occurs less than 6 months, and 90% are less than 1 year of age. So few points regarding pathogenesis of persistent diarrhea, and basically it is due to persistent mucosal injury. Why this injury occurs? Mostly because of some bacteria which body gets some difficulty in clearing those bacteria. Mostly they are E. coli and Shigella. 23% of these cases are because of Shigella, and sometimes Salmonella and Campylobacter. And some host factors are also responsible for this. Suppose like micro and macronutrient deficiency and compromised immune system is also responsible for persistent diarrhea. So now, if we consider all factors in pathogenesis of persistent diarrhea, we will get some multiple factors are responsible. In this, most important we know is the secondary lactose intolerance. Then fungal superinfection, and this occurs mainly because of use of multiple antibiotics, and diarrhea compounded by primary malnutrition that leads to enteropathy. And sometimes very often we miss that diarrhea are associated with UTI, and because of the UTI, diarrhea gets prolonged course. UTI and systemic infection and sepsis should always be ruled out if we encounter any case of persistent diarrhea. And antibiotic associated diarrhea, this is also very common, because I think, in my opinion, this is the main factor of persistent diarrhea, because without knowing the etiology, very often we prescribed so many antibiotics for control of diarrhea, and ultimately that lands into a case of persistent diarrhea. So risk factor for persistent diarrhea: very young age, they are very much prone to develop persistent diarrhea. Previous infection, suppose a baby has developed infection and before complete recovery gets another infection, so that leads to persistence of the diarrhea. Irrational use of antibiotics or multiple antibiotics also responsible. Impaired immunity also responsible. Malnutrition is a very common factor for persistence of diarrhea, lack of breastfeeding, and recent introduction of animal milk is also very much important. So now this is the pathogenesis of persistent diarrhea. You see the first one, the upper one, here the diarrhea, then there is recovery in a normal person. Then first one, here is the diarrhea, then some secondary event will occur, means there is some lactose intolerance or some other factors that leads to persistence of the diarrhea. And you see, this is second one, continuing infection. That means suppose patient has developed Shigella infections and body is not able to clear those organisms, that also lead to persistent diarrhea. And delayed recovery means here the fault is in the body. Patient himself or herself is not able to clear those organisms and diarrhea become persistent. And another, repeatedly patient is getting different type of infection. Suppose patient has developed E. coli, then recovering, suddenly develop Salmonella, then recovering, then develop Shigella, and in this way it will continue. And so multiple infections is also a responsible factor for persistent diarrhea. So now natural history. So acute diarrhea, 70% resolve in 1 week, and this is we are handling most of them in our clinics and in ward and chambers. Acute diarrhea, 90 to 90% resolve in 2 weeks. So majority 1 week and 90 to 95% resolve in 2 weeks. Then 5 to 10% will become persistent. And in this persistent diarrhea, majority subsides in 4 to 6 weeks. And very few will persist 6 to or more than 6 to 8 weeks. And in these cases, we have to think of some other factors may also be responsible for this persistence. So what are those factors? You see, cow milk plus soy allergy, immunodeficiency, celiac disease, lymphangiectasia, cystic fibrosis, and anatomical causes. I will discuss this in detail later on. And these cases to be referred to a specialist, and these cases is beyond the scope of pediatrician to manage. So risk factors for death. 6 months of age or less is a risk factor for death. Severe dehydration is also a risk factor. Use of total parenteral nutrition. Systemic infection, most important. So systemic infection is the most important because a children less than 6 months may have sepsis. If we don't recognize this sepsis, we concentrate on managing diarrhea. Ultimately, patient will die because of the sepsis. Stool pathogenesis. Very often we send stool sample for REME or isolation of the microorganism, but very rarely that will help because those bacteria may be excreted normally in healthy person. But if we analyze those organisms, mostly we will get Shigella, Salmonella, E. coli. In this E. coli, enteropathogenic or enteroaggregative, Giardia, Cryptosporidium, and Entamoeba histolytica. So recovery of the stool pathogen doesn't mean that patient has that infection because healthy person sometimes may excrete those organisms with stool. So now our aim will be, if we want to manage properly, we have to concentrate on diarrhea and its consequences, infections, and malnutrition. So now this is the Vcr cycle. And I think this is the most important cycle for persistence of the diarrhea. So prolonged diarrhea we are handling, and this is because of the small bowel mucosal injury that will lead to venous atrophy or loss of rasvator enzymes that will lead to secondary lactose intolerance, malabsorption, hypoalbuminemia, bacterial overgrowth. And this in turn again lead to persistence of the diarrhea. Again, this persistence of the diarrhea will lead to malnutrition. Malnutrition itself can cause small bowel mucosal injury, and malnutrition leads to compromised immunity that will lead to fungal infection, and that will also lead to small bowel mucosal injury. And because of this infection, sometimes we use to prescribe antibiotics that will also lead to superadult bacterial and fungal infection that will lead to small bowel mucosal injury, and some other factors like food allergens, soy or bovine, persistence of infection will also lead to small bowel mucosal injury. So this ultimately, this is a VCR cycle. If we want to manage these cases, we have to break this VCR cycle. So see how we can break. So this is the VCR cycle we have to break. And so if we want to manage, so we have to concentrate on, or we have to manage stepwise fashion. First step, resuscitation, then identify infection, then if management of lactose intolerance if there, dietary therapy, and nutritional supplements. And you see in these 5 steps, prescription of the antibiotic is not required at all. So prescription of the antibiotic is required only in few situations that I will discuss in next few slides. So step 1, fluid resuscitation, ORS or with linear lactate, correction of electrolytes, and correction of hypoglycemia. This will stabilize the patient. Then identify infection. May have respiratory UTI and sepsis. So if we overlook these infections, we will not be able to control persistent diarrhea. Then examine perineum and oral cavity, because in this area we may get some clue in the form of fungal infection. So we can think of it may be a case of fungal diarrhea and need antifungal. TLC, DLC will indicate systemic infection. Blood and urine culture will also identify infection, and chest X-ray may also help us to rule out other systemic infections. And according to this site or causative organism, we have to start appropriate antimicrobials. So stool examination, very frequently prescribe examination of the stool, but that examination will help us very rarely, except in few situations. So no role of routine stool culture and isolation of the pathogen. Stool, if we get some fungus, that may indicate patient may have fungal diarrhea, and this is very much important, but rare, very rare. Stool for Clostridium difficile toxin in a clinical setting. Clinical setting means where the patient is getting multiple types of antibiotic and patient has developed antibiotic associated diarrhea. That may indicate in that situation we may try to isolate difficile toxin. Stool for opportunistic infection if immune deficiency is suspected, 3 consecutive fresh samples. So Cryptosporidium and other organisms can be isolated if we do 3 consecutive fresh samples in this scenario. And now see, indications of antibiotic is very, very limited. Only if we get blood in the stool, that means Shigella, systemic infections, patient has sepsis, severe malnutrition, concomitant UTI, and less than 4 months of age. Beyond these 5 reasons, there is no scope of giving antibiotics, but there is very few data whether to use antibiotic or not in case of persistent diarrhea of unknown cause on non-specific cause. There is enough scope of study in this field. So now I will show you few cases. Acute onset watery diarrhea 15 times per day for 7 days with dehydration. And history of top fed and bottle feeding is there. And there is history of catheterization, use of IV antibiotics, vesicotrottles, and probiotics. Persistent diarrhea beyond 2 weeks. This acute diarrhea now turned into a case of persistent diarrhea. And so urine CS shows E. coli and culture report came, antibiotics prescribed for 7 days, patient improved. Now another case, 4-month female child, 11 months old male child, it is a female child. So started cow milk, patient developed acute diarrhea into 2 weeks. Then this diarrhea became persistent. And you see this classical perianal excoriation, perianal rash. And this is very much suggestive of lactose intolerance. And so how lactose intolerance occurs? Lactose load in the diet, normally it is metabolized by lactase, converted into glucose and galactose and gets absorbed. But in the absence of lactase, this unabsorbed lactose will go to the colon, where it will be broken into hydrogen and lactic acid. And this lactic acid will cause perianal excoriation, and hydrogen will cause hydrogen also cause perianal excoriation, and this will a commonest cause of acidic osmotic stool and cause osmotic diarrhea. So now another clue. 9-month-old child, persistent diarrhea beyond 2 weeks, following an acute onset. Ofloxacin in 5 days, norfloxacin in 7 days. Examination shows oral thrush, and also there is thrush in the periscrotal area, perianal area, and this is a clue. Patient treated with fluconazole and patients get cured. Now another 5 years old male, acute onset diarrhea. I received ofloxacin, ceftriaxone, metronidazole, PPI, cefixime, multiple antibiotics, and diarrhea persistent beyond 6 weeks. Immune profile was done, suspecting immune deficiency, TTG-AB, suspecting celiac, sepsis screen, all are normal. Then sigmoidoscopy done, colitis found, and biopsy shows pseudomembranous colitis, and Clostridium difficile toxin was also positive, and treated in the line of pseudomembranous colitis. Antibiotic stopped, metronidazole was advised, vancomycin given, and patient got cured. So cornerstone of management is dietary algorithm. You see, cornerstone of management of persistent diarrhea is dietary management. So initially diet A means low lactose diet. If there is a failure, diet B, lactose free diet. If there is failure, hydrolyzed or amino acid formula means elemental diet. If failure, total parenteral nutrition. But in between, you have to give 2 weeks time to see the response. And sometimes there is another management is green banana diet. Green banana diet we can try here and here. I am coming to that green, how it helps. Now reduced lactose. And all of us, it is very common among us how to prepare reduced lactose. By milk half cautery, sugar half TSF, puffed rice powder 4 TSF, water half cautery, and oil half TSF. All will be mixed, and this will give calorie 96 calorie and 2.4 gram protein per 100 gram of this diet. Lactose free diet. Here egg white or chicken puri is used, puffed rice and glucose you maybe or may not be used, plus water, and this will give rise to a diet, lactose free diet, where we will get 78 kilocalorie per 100 gram and 2.3 gram protein per 100 gram of diet. So now this is a new concept, green banana formulation. And we know amylase resistant starch is present in green banana. It is not digested in human intestine. So straight away it will go to the colon, and colonic bacteria will break this into short chain fatty acid. And there will be absorption of this short chain fatty acid along with salt and water absorption, and also it is provide energy and trophic effect. So we can use very easily available, and we can use this green banana in persistent diarrhea. So how it is prepared? So we have to take one raw green banana, cook in boiling water for 7 to 10 minutes, then remove skin, take the pulp, blend and homogenized 100 gram. Along with this, you take rice 10 gram powder cooked in 1 liter of water, and add oil, glucose, salt, plus minus egg white. And this will give 54 calories per 100 ml. And this is very much helpful now. Very can be prepared very easily and very cheap also, can be used in rural setting to control persistent diarrhea. So nutritional supplements, twice the recommended dose for 2 to 4 weeks. Iron, remember iron after cessations of the diarrhea. Folic acid 1 milligram per day for 2 weeks. Vitamin A as per protocol. Potassium 2 to 3 milliequivalent per kg per day for 2 weeks. And magnesium 0.2 ml per kg per day IM for 2 to 3 days. And zinc, but can be used, but in chronic or persistent diarrhea, role of this zinc is not being established. So no major role. So monitoring their response, how we can assess patient is responding. Diarrhea, it will be less than 2 stool per day for 2 consecutive days. Adequate food intake, documented weight gain, and target is weight on the day 7 will be weight on the day 7 will be more than the weight during admission. And weight gain should be documented on at least 3 successive days and follow-up to be done. So how long should we give diet A or B? How long time we can allow after starting type A before switch over to B? Minimum 7 days trial each before failure is just declared. And if lactose intolerance is suspected, lactose-free diet for at least 21 days. So some additional drugs, antimotility drugs has no role, anti-secretory resicadotil has no role, and probiotics and Saccharomyces boulardii, no significant benefits is established in acute diarrhea. So in conclusion and recommendation in respect of persistent diarrhea is that it is mostly in our country because of unhygienic living condition, undernutrition, and coexistence of HIV with this, and poor access to good quality health care. And some other factors like mucosal injury, chronic mucosal injury is due to specific organisms like Shigella, macro and micronutrient deficiency, and other factors include young age, previous infection, inappropriate use of antibiotics, impaired immunity, lack of breastfeeding, and introduction to animal milk. And so micronutrient supplementation with stepwise diet-based regime and good supportive care is sufficient in most children above 6 months of age. And special infant formula is very rarely required. So promotion of exclusive breastfeeding in early infancy, safe complementary feeding practices, access to safe drinking water, and scientific management of acute diarrhea can significantly reduce the incidence of persistent diarrhea. So persistent diarrhea is not that difficult situations. If we consider all these things, we can very easily we can manage these situations. Now, I am switching over to chronic diarrhea, and you have to remember remember the difference between chronic diarrhea and persistent diarrhea. Both cases, it will persist more than 2 weeks. Here it is insidious onset, and mostly there is associated with manifestations of malabsorption, associated with malnutrition, intestinal and extraintestinal causes are there, underlying inherent defect, and NEH. So these are the features of chronic diarrhea. Here you see insidious onset, not acute. Malabsorption features are there. Malnutrition features are there. Intestinal and extraintestinal causes are there. And some underlying inherent, that may be genetic or other structural defect may be there. At any age it can happen. So persistent diarrhea, more than 2 weeks, acute onset, usually infective, small bowel is the site of involvement, no associated GI disease, normal gut after treatment, common in infancy, and mostly not associated with malnutrition. And majority of acute and persistent diarrhea can be managed by pediatrician. But for chronic diarrhea needs specialized investigation and needs to be referred to pediatric gastroenterologist. So this part we must remember. If we think or if you get this type of cases, early opinion of gastroenterologist, pediatric gastroenterologist should be taken. Otherwise, patient may die or may become more complicated. So now malabsorption, because chronic diarrhea and malabsorption are more or less synonymous. So what is malabsorption? It is the disturbance in the digestive and absorptive sequence of nutrition that cause the intestinal mucosa. So digestive and absorptive sequence is defective. So what are the steps of digestive? It is a solubilization, luminal digestion of macromolecules of protein, carbohydrate, and fat, and mucosal absorption. That is carrier transport, diffusion, and then post-mucosal transport. So anywhere there may be defect. And all these factors will lead to either chronic diarrhea or malabsorption. So this is a solubilization, then luminal digestion, then mucosal absorption, and absorption is carrier transport or some mediated by some carrier, diffusion, then post-mucosal transport. Anywhere there may be defect. So before going into detailed discussion, we should remember the site of absorption of the different ingredients of the food. So suppose if the liver and pancreas and biliary system is affected, there will be disturbance of the fat digestion and absorption. If suppose this distal part of the ileum is affected, that may be because of the TB, that may be because of the bacterial overgrowth, that may be because of the surgery, there will be definite disturbance of the B12 absorption, that is B12 malabsorption. If duodenum is affected because of the celiac disease and some other disease, I am coming into detail regarding this, iron will not be absorbed. So iron malabsorption. If amino acid, dye and tripeptides absorption is affected, definitely we can think that jejunum is affected because of some reasons. Glucose and fructose is absorption affected, jejunum will be affected. Fatty acid, triglycerides, water soluble vitamins, jejunum and proximal will be affected. Cholesterol will not be absorbed if there is some defect in the duodenum, jejunum and ileum. And water and monovalent ion absorption will be affected if the small intestine and colon are affected. So epidemiology of diarrhea, you see, 85% of the diarrhea is acute and will be cured very easily, and it occurs mostly less than 5 years of age. 10% of diarrhea is persistent, that I have discussed, and mostly persistent occurs less than 2 years. Peak age is 7 to 14 months. And chronic diarrhea incidence is very less. Chronic diarrhea or malabsorption is only 5%. Any age it can be affected, but there is a subset of diarrhea which is called intractable diarrhea of infancy. That is also included, very dangerous type of diarrhea. I am coming to that, and it occurs only in 5%. So chronic diarrhea is a complex disorder, and this is because of the interplay of these factors: osmotic, secretory, inflammatory, motility, and combined. These factors are responsible for developing chronic diarrhea. So it is a complex phenomenon, and it will be very easy for us if we remember these mnemonics. Alpines. Alpines means A, autocrine, luminal, paracrine, immune, neural, and endocrine. All these factors will lead to alteration of this either paracellular pathway or epithelium or muscle or blood flow. And these 4 factors will lead to increased permeability and defective transport and defective motility. And all these factors will lead to persistence of diarrhea, that will lead to chronic diarrhea. Alpines. So classification of chronic diarrhea according to the part affected. Intestinal cause. Intestinal cause even may be internominal or mucosal. Pancreatic cause, cystic fibrosis or chronic pancreatitis or Schwarzman-Diamond syndrome. Bile acid, chronic cholestasis or ileal surgery. Neurohormonal, hyperthyroid, diabetes mellitus, Vipoma, and Zollinger-Ellison syndrome. Factitious, very often we experience this after taking heavy meal in some marriage ceremony and other things. After taking heavy carbohydrate meal, next morning we used to have this experience. And spurious, constipation with fecal soiling. It is very interesting. Most of the cases are being treated as a case of diarrhea, but ultimately this is diagnosed to have some heart sprung or other constipated disease which can cause constipation. Here what happens? The solid stool is impacted and loose stool from above is coming by the side of the solid stool and resembling diarrhea. Functional, IBSD, toddler's diarrhea, post-infective IBS, all can lead to chronic diarrhea. So now in detail, intestinal disorders. Again, intraluminal osmolarity will be affected in carbohydrate malabsorption, either congenital or acquired, excessive intake of carbonated drink. It is also because of the affections of the intraluminal osmolarity. Altered mucosal integrity, and all these also lead to chronic diarrhea because of various infections I have told already: celiac disease, CM, cow milk protein intolerance, IBD, tropical and environmental enteropathy. Altered immune function, common variable immune deficiency, IgA deficiency, and autoimmune enteropathy. Altered transport function. This is very important. Very often we get this type of cases: congenital chloride diarrhea or sodium or hydrogen diarrhea, zinc deficiency. We have seen acrodermatitis enteropathica because of this defect in this part. Abital hypoproteinemia also we used to get this type of cases. Altered digestive function, enterokinase deficiency. Altered surface area because of the celiac or short bowel syndrome. Altered secretory functions because of the tumor secreting VIP or calcitonin. Vasoactive intestinal peptides. Altered anatomic structure, intestinal lymphangiectasia. This is also a very common cause of chronic diarrhea presented in the very early part of life. I am coming in detail regarding this. And intractable diarrhea of infancy, this we should remember. Very often we get some newborn in the early part presents with intractable diarrhea, not responding at all to any fluid therapy, antibiotics, and all these things. Ultimately, patient becomes severely dehydrated and alteration of the acid-weight balance and dies. And this is a unique subset of chronic diarrhea. More than 2 weeks, age usually occurs less than 1 year, sometimes less than 2 years. And why this patient dies? Because this patient requires specialized enteral nutrition or prolonged TPN, which most of our centers is not able to do this, may require intestinal transplant. This is also not possible, and site of involvement of the small bowel. I am coming detail in this regarding these factors. So chronic diarrhea in infants and intractable diarrhea in infants, because this may be because of some congenital causes or acquired causes. Codes, this means congenital diarrhea and enteropathies. Some cases there is villus is normal, some cases villus is atrophic. And acquired infectious immune deficiency, food protein allergen, structural and post-surgery short bowel. All these factors will lead to chronic diarrhea in infants, or another name is intractable diarrhea of infancy. So you see in detail regarding these 4 factors. This type A, it is the epithelial electrolyte transport is defective. All 4 factors lead to congenital diarrhea and enteropathies, which presents in the very early infancy. So group A, epithelial electrolyte transport is defective. Group B, epithelial enzyme and metabolism is defective. Epithelial trafficking and polarity is defective in group C. I am giving example of all these 4, and this is the enteroendocrine factors is defective. Now see. Group A, congenital chloride diarrhea, sodium diarrhea, glucose galactose malabrasion, acrodermatitis enteropathica. This is because of the epithelial electrolyte transport defect. Now sucrose isomaltase deficiency, lactase deficiency, abital hypoproteinemia. This is epithelial enzyme and metabolism is defected. Microvillus inclusion disease. This is mostly not diagnosed in our setup. Tufting enteropathy and trichohepatic syndrome. This is because of the epithelial trafficking and polarity is defected. And enteroendocrine X-linked autoimmune enteropathy and some other rare conditions because of the defect in the enteroendocrine part of the epithelial cells. So approach, very important for PGTs, approach to chronic diarrhea. So first we have to take detailed history, then complete clinical examination, then relevant investigation, and then appropriate treatment. In the history, identify etiology. How? You think age of onset, difference between organic and functional cause, stool characteristic, detailed dietary history, associated symptoms, drug history, family history, underlying disease. And side by side, you assess the growth and development, macro and micronutrient, and vitamin deficiency. So age, very simple. If we in history, if we ask the age of onset of the disease, we can have a very good idea regarding the etiology. So if it starts in the newborn period, mostly because of the microvillus disease, that means microvillus inclusion or tufting enteropathy, or congenital chloride diarrhea, or short bowel syndrome. One point I must say regarding congenital chloride diarrhea. It is because of the defect, as I have told already, electrolyte transport. Here the stool is like urine like stool. It is very difficult to differentiate whether it is urine or stool. One point. Another point is that most of the diarrhea is associated with metabolic acidosis. In chloride diarrhea, we will get metabolic alkalosis. Very frequently asked to PGTs. If the onset is 2 weeks and 2 months, we have to think of cow milk protein intolerance if started cow milk in this age, taptic enteropathy, autoimmune enteropathy, and codes. If the onset is 6 months to 2 years, it is CMPA, lactose intolerance, immune deficiency, and small bowel surgery. 2 years to 5 years, celiac or immune deficiency, lactose intolerance, parasitic manifestations, and inflammatory bowel disorder. More than 5 years, it is mostly because of the inflammatory bowel disorders, TB intestine, celiac disease, carbonated drinks, furious diarrhea, common variable immune deficiency, and post-infective IBS. This is also very important. We are getting now cases after recovering from the COVID. We are getting diarrhea cases very often, and some says there may be some relation between this IBS and COVID infection also. Difference between organic and functional diarrhea. This is the first step. Before going in detail, we have to differentiate either it is organic or functional. Functional, always duration is long, organic duration is short. Constitutional symptoms less marked, there is a mark. Weight loss, there will be no in functional, but yes in organic. Appetite present, functional, and organic appetite absent. But again, remember, chronic pancreatitis causing diarrhea usually associated with good appetite. Nocturnal diarrhea, no in functional, but organic, there will be history of nocturnal diarrhea. Gastrocolic reflex, yes, there will be no. And anxiety symptoms, as it is functional, so always there will be some anxiety component. In organic, there will be no such. Now another important and most important, you see the stool characteristics. You ask frequency, volume, and content or consistency. Then you differentiate small bowel or large bowel. Then you differentiate osmotic secretory and dysmotility. Then you see whether it is painful or painless, associated with blood or not, inflammatory and non-inflammatory. So these 6 points are very much important if we want to approach to a case of or want to reach to a diagnosis. With this, we can narrow down, because there are innumerable causes of chronic diarrhea malabsorption. If we take the history in detail, we can narrow down our differential diagnosis. Now see, stool characteristics, 3 determinants: frequency, fluidity, and volume. There may be alteration of the frequency, there may be alteration of the fluidity or liquidity or consistency, or increased volume. Either single factor will be affected or combination will be affected. So now you see, very much important. If the frequency, volume, content, we consider these 3 factors. If the frequency is high, volume is high, content is watery, definitely it is a secretory diarrhea. If the frequency is high, volume is low, content is mixed, definitely it is a large bowel diarrhea. If the frequency is normal or high, volume is high or normal, watery or mixed, definitely it is a small intestine. One point you think, if the volume is very high, mostly the cause of site of descent is the small intestine, because maximum amount of water will be absorbed from the small intestine. If the small intestine is normal, water will be absorbed, stool will become less. So in large intestine diarrhea, always volume will be less. Now this is another, we have to remember this Bristol stool chart. Severe constipation, separate hard lumps. Mild constipation, lumpy and sausage-like. So these 2 abnormal. Type 3 normal, sausage shape with cracks on the surface, normal, and like a smooth soft sausage or snake, it is also normal. Now you see diarrhea, soft blobs with clear-cut margins. It is a lacking, indicates that its diet is lacking in fiber content. Mild diarrhea, massy consistency with ragged edges. There is no edges are ragged. And type 7, severe diarrhea, liquid consistency with no solid pieces. So with this, we can also have some idea regarding the diarrhea and constipation. Now, stool characteristics, etiology can be identified if we think inflammatory diarrhea, there may be blood or mucus in the stool. Fatty diarrhea, stool is containing fatty or oily. Pancreatic disease or hepatobiliary system is affected, we can think. Fermentive diarrhea, definitely carbohydrate malabsorption, mostly in the form of lactose intolerance. Fluid diarrhea, it is either secretory or bacterial overgrowth, as I have told already. Factitious diarrhea and functional diarrhea, these two can be differentiated or identified very easily by taking the history. Now, this is also another very often should be used, but we are not using this. Differentiate whether the diarrhea is because of the small bowel or large bowel. Large volume in small bowel and small volume in large bowel. Not very frequent. That means frequency in small bowel diarrhea is less and very frequent in large bowel. Bulky, watery, massy, undigested matter, it indicates small bowel is affected. Loose with blood and mucus indicates large bowel is affected. Abdominal bloat, if present, we think small bowel. If no abdominal bloat, we have to think large bowel is affected. Abdominal discomfort relieved by defecation indicates small bowel. Abdominal pain not relieved much by defecation, it is a large bowel. Rumble or borborygmy, obviously we have seen this in the lactose intolerance. Here it will be present and large bowel, there will be no rumble or borborygmy. Flatulence also will be there in small bowel, no flatulence in large bowel. Smell offensive, obviously in small bowel, no, not offensive in large bowel. No tenesmus indicates small bowel, tenesmus indicates large bowel. Constitutional symptoms plus minus in small bowel, always there in the large bowel. Dehydration usually associated with small bowel. No dehydration means it is large bowel. Because why there is dehydration? Because water is mostly will be absorbed from the small bowel. So small bowel affected means there will be more water loss, more dehydration. Now you differentiate whether it is a osmotic diarrhea or secretory diarrhea. Osmotic diarrhea means large, loose to semi-solid. Secretory diarrhea, large, watery. So huge amount of water is coming up. Abdominal discomfort, postprandial. You think of lactose intolerance. It is osmotic diarrhea. Abdominal distension, if only there is paralytic ileus, we will get abdominal distension, otherwise not. Flatulence, osmotic diarrhea. No flatulence, secretory diarrhea. Perianal excoriation, again you think of lactose intolerance will be there. Osmotic diarrhea, no perianal excoriation. Stops when offending food is withdrawn. Does not respond to withdrawal of the food. No dehydration, osmotic diarrhea. Why not? Because sodium loss in osmotic diarrhea is very less. And dehydration is more because secretory diarrhea, what sodium loss will be more. Not ill looking, always ill looking. Stool sodium is less than 50 and stool sodium more than 90. You think the huge amount of sodium loss in secretory diarrhea. And stool 2 into sodium plus potassium is less than osmolarity, is indicator of osmotic diarrhea. And if it is more than 290, it indicator of secretory diarrhea. Now, is diarrhea associated with abdominal pain? This is a very common history. Crampy pain, decrease after contents are expelled, indicates topical sprue, celiac disease, giardiasis, primary lymphangiectasia. Pain persists, intestinal TB, celiac disease, whipples, and chronic pancreatitis. Inflammatory or non-inflammatory? Non-inflammatory means celiac disease, giardia, tropical enteropathy, lymphangiectasia, abital hypoproteinemia, bacterial overgrowth. If inflammatory, tuberculosis, Crohn's disease, ulcerative colitis, eosinophilic, and whipples. If diarrhea is associated with bleeding, chronic diarrhea associated with bleeding or not bleeding. If there is no bleed, it indicates celiac disease, tropical sprue, lymphangiectasia, giardiasis. If there is blood is present, you see how the differential diagnosis has been narrowed down. Intestinal TB, IBD, allergic colitis, or eosinophilic colitis. Only 4 causes are there in if blood is present in a case of chronic diarrhea. Now think of, does the features of malabsorption? Malabsorption again may be anything, carbohydrate, fat, protein, iron, vitamin B12, folic acid, anything cannot be absorbed properly. So if commonly these three, carbohydrate malabsorption means generalized weakness will be there, bloating, flatulence, abdominal discomfort, bodovergmy, and perianal excoriation is a very good sign. Fat malabsorption, always stool will be oily stool with lots of body fat and steatol. Protein malabsorption, loss of somatic protein leads to less muscle mass, visceral protein loss, edema and ascites. So edema and ascites is very, very much indicator of protein malabsorption. So now these points are not that important, but even we have to remember differentiating between malabsorption and maldigestion. Very sometimes when we ask, malabsorption means stool fat will be 2+. Here is a very maldigestion means huge amount of fat. Fatty acid crystal will be there in malabsorption. There we know in maldigestion. Flatulence will be there in malabsorption. Anemia, folate or B12 will be there in malabsorption. Hypoalbuminemia will be there. Stool volume will be more due to catalytic action of the free fatty acid on colon. But here there will be not much. So growth and development, obviously, if depends upon the history. If the longer the history, more there will be hampering of growth and development. So we have to take birth weight, history of growth failure, growth charts. Recent loss is very much important. Recent loss, that means acute and a chronic case. Well nourished, motor and social milestone also should be taken into account. Now, few symptoms, also indicators of chronic diarrhea. If fever is present, obviously it is maybe because of TB, IBD, lymphoma, or HIV. If wheeze are there, chronic diarrhea with wheeze, very good clue. Cystic fibrosis, immune deficiency, food allergy, recurrent infection. Chronic diarrhea with history of recurrent infection, always think of immune deficiency. Vomiting is there, protein intolerance, COX or IBD. Increased appetite, because we have seen most of the cases are associated with decreased appetite. But if you get history of increased appetite, it is mostly pancreatic insufficiency. Abdominal pain, TB, IBD, lactose intolerance. Arthalgia, obviously, Crohn's disease or ulcerative colitis, maybe there. Jaundice, bile acid diarrhea. Thirst, disaccharide intolerance. Anorexia, malabsorption, and rash, food allergy on IBD. So now, this is also very, very good clue. Exclusive breastfeeding having severe persistent diarrhea in the newborn period. Congenital diarrhea or enteropathy. Onset after starting animal milk, CMP. Starting wheat cereal, celiac disease. Following every milk feed, lactose intolerance. Following intake of cereal, sugar, and fruits, sucrose and isomaltose deficiency. Diarrhea decreases on withholding food, osmotic diarrhea. Increased appetite, very good indicator, pancreatic insufficiency. Now, obviously, we have to take history, treatment history, drugs, whether getting chronic laxative, antacid, antibiotics, immunosuppressives, mycophenolate, mofetil, whether surgery is done. So all history should be taken. Family history is also a good clue. Cystic fibrosis, celiac disease, lactose intolerance, congenital venous disorder, IBD, all are very much important, and underlying illness, chronic liver disease, thyroid disease, diabetes mellitus should be asked whether the underlying disorders are there or not. Complete clinical examination is also should be done after taking history and all these things. Complete clinical examination, general examination, anthropometry, medium circumference, all are indicators of malnutrition. Features of apathy, lethargy, pedal edema, protein malabsorption, clubbing, cystic fibrosis, jaundice, hepatobiliary disorder, anasarca, also protein, cheilitis, vitamin B and B complex, xerosis, vitamin A absorption defect. So all are clue. If we consider or take detailed history, any one of the clue we will get, and from that clue we can proceed and can reach the diagnosis. Now, systemic examination is also very much important. Whether hepatosplenomegaly is there or not, free fluid is there or not, rectal examination should definitely be done. Respiratory for cystic fibrosis and other things, cardiac and CNS should also be examined in detail because of protein and vitamin B12 or some other vitamin deficiency can cause alteration of this cardiac and CNS function. Go ahead, your notes. এই নিয়ে যাও, চলে গেল, নিয়ে যাও, তাতে জাস্ট এ মিনিট। এই এই, কোথায় চলে গেল? জাস্ট এ মিনিট। যে কোনো প্রশ্ন রান্না সেখানে পেয়ে যাবে। হ্যাঁ, ভিজিবল। হ্যালো, নড়ছে না যে, নড়ছে না যে। প্রচুর লোক আছে। আরে রূপক, হ্যাঁ কি খুলবো? জাস্ট এ মিনিট, ইজ এ হ্যান্ড। দূর কি যে বলে, নড়ছে না। না কেটে গেছে, হ্যাং করে গেছে, এটা হয়তো চালাবো। আরে ক্লাসটা দিয়ে না, ক্লাস বাবু তোকে নিয়ে আচ্ছা সমস্যায় পড়েছে এবারে। খোলাই আছে, ক্লাসটা দেন এখানে, সার্চটা দে, আবার শেয়ার কর। হ্যালো, ভিজিবল? হ্যালো, দেখ আসছে,
আসছে আসছে
আসছে,
হ্যাঁ,
হ্যাং করে গেছিল। So this is about complete clinical examination. Now some basic investigation. CBC and peripheral smear, macrocytic anemia and folate indicates folate or B12 deficiency. Microcytic anemia indicates iron deficiency. Thrombocytosis indicates Crohn's disease. Lymphopenia, very good clue. Lymphopenia, it indicates intestinal lymphangiectasia. Acanthocytosis indicates abetalipoproteinemia. Stool pH, reducing substance, stool osmotic gap also indicates there may be lactose intolerance or osmotic diarrhea. Parasites indicates Giardia tropozoite, indicates some it is because of the parasites. Transaminase elevated in celiac disease. Low albumin, always I have said already, it is protein losing enteropathy or Crohn's disease or intestinal lymphangiectasia. Low globulin indicates immunoglobulin deficiency. Total protein, if there is low, indicates either intestinal lymphangiectasis or protein losing enteropathy. Low potassium is a very good clue, indicates secretory diarrhea. And CRP and ESR raised, if there, indicates always IBD or TB. So now some other specific investigation. If TTG antibody is more than 100, elevated, it is in celiac disease. Fat globules is 100 per high power field, indicates steatoria. That indicates there is some fat malabrasion is there. And 24-hour stool fat estimation, if it is done, and if it is more than 14 gram per day, it indicates there is some malabrasion of the fat. Fecal elastase is a very good indicator of chronic pancreatic exocrine insufficiency, and it will be less than 200 microgram per gram of the stool. Stool citrulline indicates decreased small intestinal function mass. Fecal calprotectin also a good indicator of intestinal inflammation like your ulcerative colitis and Crohn's disease. Stool alpha antitrypsin indicates present in protein-losing enteropathy. D-lactate is a good indicator. If it is a more than 1 micromole per liter, indicates small intestinal bacterial overgrowth. Immunoglobulin profile also good indicator of indicating of chronic variable immune deficiency or functional T cell disorders or HIV also. Thyroid profile, it may be hyper or hypothyroid. Serum gastrin indicates patient having Zollinger-Ellison syndrome, and some other tests not done routinely nowadays. Breath hydrogen ion test for lactose intolerance, D-xylose for small intestinal function, sweat chloride for cystic fibrosis, and genetic studies. So some radiological investigations are also very much important. Plain X-ray chest and abdomen indicates TB or some other abnormality. Ultrasound of the abdomen, CECT abdomen, Crohn's disease and intestinal TB. MR enterography also for Crohn and intestinal TB. You see in X-ray, pancreatic calculi in chronic pancreatic pancreatitis, chronic calcific pancreatitis we are getting. And you see here CECT abdomen showing long segment thickening of ileum in Crohn's disease. The endoscopy with histopathology is also a very good, though scope of this examination with us is less. Upper GI duodenal biopsy, celiac disease, intestinal lymphangiectasia, and parasites. It will be very easy to diagnose with upper GI endoscopy with duodenal biopsy. Ileocolonoscopy with biopsy indicates Crohn's disease or diagnose Crohn's disease and ITP. Double balloon enteroscopy with biopsy and capsule endoscopy only for visualization. So this is excellent tool for mucosal disease. Now you see, I will show you some figures. You see, this is a endoscopy scalloping of the second part of the duodenum. Endoscopy and histopathology showing atrophy of the villus, and it indicates celiac disease. Now you see colonoscopy, there is an ulcer in the colon, and histopathology showing epithelioid granuloma, indicates Crohn's disease. And endoscopy here in this showing snowflake appearance, snowflake, and histopathology showing intestinal lymphangiectasia. This is a dilated lymphatics indicating intestinal lymphangiectasia. Duodenal mucosa showing strongyloides larva. So you can see how much biopsy and histopathology is important for diagnosis, rare situations. So now I have reached the last part. Treatment. Ensure adequate calories in all children using simple home available fluid and diet. Enteral nutrition preferred. Always we should try to use the intestine as a source of giving nutrition. Only rare situations, other methods of total parenteral nutrition can be used, and supplementation of folic acid, zinc, and vitamin A is very much essential. So diet modification depending upon the some situations, specific modification. If cow milk protein intolerance, very common, avoid all animal milk up to 1 year of age, and sometimes it may require 2 to 3 years. We have to avoid cow milk. Lactose intolerance, avoid milk or decrease load of lactose. Celiac disease, lifelong gluten-free diet. Intestinal lymphangiectasia, use medium chain triglyceride. Congenital sucrase isomaltase deficiency, avoid sucrose, fructose, and maltose. Carbohydrate overload, avoid carbohydrate and sweetened drinks. Chronic constipation with fecal swelling, increase fruits and vegetables in diet. Acrodermatitis enteropathica, oral zinc, lifelong. Cystic fibrosis, for diarrhea, pancreatic enzyme deficiency, 1000 units per kg of lipase per meal. Parasitic infestations, antiparasitic. Combined variable immune deficiency, IVIG therapy. Crohn's disease, we know, steroids with some immunosuppressive and biologicals. Congenital chloride diarrhea, sodium potassium supplementation with PPI, lifelong. IBS type D, that means diarrhea type IBS, reassurance of behavioral therapy. Intestinal failure and short bowel, intestinal transplantation. So now I will summarize with a single slide. So practical approach to a child with chronic diarrhea. First, you see whether child is well or unwell. If the child is well, think of lactose intolerance, constipation with overflow, carbonated drink with carbohydrate malabsorption, and IBS. Now, if history, stool characteristic, clinical examination, and growth chart shows patient having malnutrition, growth retardation, and dehydration, then possibilities are, if the stool is watery, think of secretory diarrhea. Means microbilous inclusion disease, hypoma, sucrase isomaltase deficiency. If the stool is massy and loose stool, celiac disease, CMPA, parasitic infestation, avital hypoproteinemia, and lymphangiectasia. And if the blood and mucus is present, IBD, TB, HIV, and lymphoma. If the fatty diarrhea or oil in the stool, then you do fecal elastase. If fecal elastase is positive, it is because of either cystic fibrosis and chronic pancreatitis and protein losing. And if the fecal elastase is negative, it is the cholestasis. And depending upon this, we can restrict our investigation and we can pinpoint our diagnosis. So message is that chronic diarrhea is a complex entity, maybe due to intestinal or extraintestinal causes. Systemic approach helps in evaluation. Timely referral to paid gastroenterologist is crucial. Endoscopy, histopathology, imaging, and genetic studies aid in diagnosis. Specific treatment is recommended depending on diagnosis. So this is all about regarding chronic diarrhea and persistent diarrhea. Thank you all for patience.
Thank you, Dr. Naik. Thank
Yes.
you, Dr. Naik, for your comprehensive discussion, which will be very, I think, very much of help to the postgraduate students. And thank you all for participating and your patient hearing.
So any question, if you have any, chat box, I will answer later on. So once again, thank you all.
Thank you.
Thank you. So Doctor leaving now.
Okay,
Hello.
leave. Okay. Thank you.
সোমনাথ,
বলছি ক্লোজ করবো?
হ্যাঁ ক্লোজ কর।